The session is ready to begin. The session is sponsored by Comagine Health. Sarah Halvick from Comagine Health will introduce the session. Following her remarks, Brantley Scott from the Utah Department of Health will moderate this session. Sarah, you have the floor.
Thanks, Charles. I'm Sarah Halvick from Comagine Health. You may have known us as Health Insight or QCore previously. We are now Comagine Health. But it's my pleasure to introduce you to today's session, using data to contain costs. This topic couldn't be more timely. As we just heard in the plenary, our economy has dropped quickly into a resource-constrained environment. We're being asked to do more with less in every aspect of our lives, and healthcare provision and payment has been turned upside down, and people are losing their jobs and insurance. Medicaid enrollment has swelled. Some people are skipping or delaying medical care, and primary care and other services have shifted to telehealth pretty much overnight. Caring for individuals with COVID infections has rightfully captured the world's focus, but we must also remember that life goes on outside of those incident infections. Babies are being born, people with chronic pain are still in pain, those with chronic conditions are still managing or dealing with the effects of those conditions. Opioid overdoses have increased, and preventative care remains critical to the future health of our communities. As individuals and as a healthcare system, we are being asked to do more with limited resources. So, using data to make decisions and contain costs, specifically by measuring and reducing low-value care and increasing the affordability of healthcare, is more critical today than ever. So thanks, NADO, our organizer, Brantley Scott, and today's speakers for bringing this conversation and your great work to light. Thanks.
All right, thank you, Sarah, for that introduction. So I'm excited to be moderating this section. Will give a brief introduction of our first three speakers. And so our first speaker that we have the pleasure of hearing from is Mark Friedrich. He directs the Center for Value-Based Insurance Design and is a professor of internal medicine at the School of Medicine and a professor of health management and policy in the School of Public Health at the University of Michigan. We will then hear from Beth Boas and Kyle Russell. Beth is the president and CEO of the Virginia Center for Health Innovation, a nonprofit established in 2012 to accelerate the adoption of value-driven healthcare in the Commonwealth. Kyle Russell oversees the analytical reporting and strategic planning for all data collection programs administered by Virginia Health Information. Kyle holds a Master's of Science in Decision Analytics and a Bachelor's of Science in Finance from Virginia Commonwealth University, where he was a Dean Scholar Awardee. And then without any further ado, I'll turn the time over to Mark. Take it away.
Brantley, thank you very much. Good afternoon and good morning, everybody. It's a great pleasure to be here at NATO. I'd like to thank Norm Thurston and his team. He's done an amazing job. And Sarah, you could not have set us up better for our session this afternoon. And we hope that we hear from a number of the NATO attendees on their issues regarding how the coronavirus pandemic has turned our lives upside down in both the delivery and infrastructure of healthcare. As a practicing general internist and who's been only intermittently on the front line, next slide, you could see most importantly that before we get into our content here, we have to send our thanks to all the people across the world who are going above and beyond and doing wonderful things to fight this pandemic. So hail certainly to the front line. Next slide, please. So we'll get started here. And exactly as Sarah said, as Beth and Kyle know, I've been working for 3 decades trying to figure out how to spend our healthcare dollars better, and why it's such a pleasure to be here with NATO, that it's data and the use of all payer claims databases and other data sets are going to drive better decisions moving forward. And as we get more into the election cycle, even though, as Sarah said, coronavirus will remain the top line, healthcare costs and healthcare access will remain a top issue for Americans. And we're trying our best to find solutions that protect consumers, reward providers, and preserve innovation. And I think it's only going to be harder now, given the fiscal situation that we're in. So even though the healthcare system has taken a hit, I think almost everyone agrees that there's more than enough money in the U.S. healthcare system. It's just that we spend it on the wrong services, on the wrong patients, and in the wrong places. And as deliberations will go on at this meeting, at the meeting that you're sharing this afternoon, and in all health policy discussions will be how we pay for care. But we also have to understand that even if we get the provider side right, we also have to figure out ways to better engage consumers to seek care in a quality-driven, patient-centered, and cost-effective way. Next slide, please. So the coronavirus, as Sarah said, has kind of turned everything upside down. And if you go to the next slide, Brantley, I'll tell you that we had made some progress regarding improving efficiency in healthcare services. But as we all know, I hope you all know The Onion, this is a bit of a satire. But while I've listened to stakeholders pleading poverty for 30 years, I do finally have some sympathy for both employers and public payers, as well as my colleagues who are providers. And what we need to do is keep everybody whole, but make sure that we spend our dollars on services that make Americans healthier. So I have written a lot about how we should be thinking about restoring efficiency in the post-COVID era, and one of which is to not just do things to do things. And rushing people into unnecessary or wasteful surgery is not the answer to this. And I'm hopeful that NATO members can help us use data to help decision makers spend our money on the things that make Americans healthier and prevent the resurgence of those services that were being used that were not making us healthier at all, and then sometimes actually creating some harm. Next slide. So this is what I hope, the conceptual model that a group from Tufts and I published in the American Journal of Managed Care last night, is that for better, for worse, and Beth and Kyle have seen this before, although we can't take credit, as you see the blue line, high value services, and green line, low value services, the coronavirus pandemic has led to a dramatic increase in all services, high and low value. I think the crux of the discussion that we'd like to have today, and what Mr. Thurston was so interested in, is that perhaps we could use data that you generate to lead to a rapid resurgence of the care that we needed to do and may have to spend more on, hopefully, in the post-COVID world, and pay for that by keeping the low-value services that we shouldn't be buying that are now suppressed, that outline at a very low level. Next slide. So the three ways to do that, I think, are fairly straightforward. First is to pay for value. And while that's above my pay grade, and I know Mr. Thurston and his team have thought a lot about that, let's pay more for the things that we should be doing and less for those that don't. Let's leverage the widespread adoption of technologies, data sets like the APCDs, and things specifically like electronic medical records to prioritize high-value care and care of patients who are most in need, and make it harder for clinicians and patients to get those services that we know we shouldn't be providing. And most importantly, as Sarah set up so beautifully, as a guy who's tried to improve access and affordability for 30 years of high-value services, we have to figure out a way to pay for it. And one of the easiest ways to pay for increased generosity of coverage of high-value services is to pay for it with the reduction in the utilization of low-value care. In other words, rob Peter, the low-value care guy, to pay Paul, the high-value care person. Next slide, Brantley, please. So because I have want to be remembered as a high-value care guy, but my board of directors and several colleagues, like many on the phone today, have pushed me to become a low-value care guy, I have become someone who's become intensely interested in the identification, measurement, reporting, and removal of low-value care. Next slide, please. And I think it all could be summarized up into this slide quite quickly, is how do you pay for high-value care in an insurance situation? One is you could raise premiums on everyone, which was not politically feasible before the pandemic, certainly not at all feasible now. Second is to raise deductibles and copayments, which actually has been the norm. And to use the word norm again, Norm Thurston knows that for well over 15 years, I've been fighting the use of these blunt instruments, which I view as a tax on the sick. So the best way to pay for increased generosity of high value care is to get rid of low value care. Sadly for me and sadly for you, it's measured in the hundreds of billions of dollars. And we have embarked on a national agenda with individuals like Beth Bortz and Kyle Russell to bring attention to some easily identifiable services that might be able to create headroom by removing them to be able to provide more plan generosity. And these are 5 that our low value care task force has identified, but there are a number of organizations who have identified low value services that we believe can make up millions, if not billions of dollars to pay for high value care more generously. Next slide, please. So there is momentum around identification and measurement of low value care. This is a paper that was published just this month by my colleagues from UCLA and I, looking at waste in the Medicare program using the Milliman MedInsight Health Waste Calculator, which is a tool that's been used in public and private databases, including APCDs that I'll talk about, to identify services that make up a significant amount of wasteful spending. Next slide. But I want to spend the last of my allotted time talking about a paper using 4 states' all-payer claims databases. I hope some of you, if not all of you, know about it. Norm will make a link available to all attendees that will take you directly to a button to get this report. This was a multi-state, multi-collaborative assessment to look at low-value care and wasteful spending across 4 states using APCDs. The next slide shows that although I thought that all APCDs were the same, we know that there are some differences. So in our first assessment, we wanted to use those 4 states' data that had the same apples to apples comparison. So this included commercial and Medicaid data for the states of Virginia, Washington, Maine, and Colorado. And we saw just the 47 services identified by the Health Waste Calculator led to nearly $1 billion a year in those services. And despite lots of conversations about these services and the Choosing Wisely implementation, there really wasn't a significant drop in spending, either total waste or PMPM, on those services between 2015 and 2017. Next slide, I'll just show you quickly, which is something that those of you who know me that I care a lot about, was only the spending in the hundreds of millions of dollars across these 4 states. Out-of-pocket spending, which, as Sarah said, is going to be even more and more constrained, was a double-digit percentage of the millions of dollars spent in each state. Meaning that while patients couldn't afford their insulins, their doctor visits, and their rehabs, they had to spend out of pocket on services that were not making them healthier, in some cases actually making them less well. Next slide. And it's when you see here that when you think about moving forward, and this is a perfect handout to the Virginia folks and other states, the good news is that we looked at the top 10 by volume across these 47 measures in commercial Medicaid. We found that in all states, greater than 2/3 of the wasteful spending, and some states up to 80% of the spending, were identified in the top 10 services, allowing implementation of pilot programs to show that these services can in fact be reduced and the savings spread around to other high value services. Next slide. So I'm just going to quickly say that one way to pull all this together is a new coverage design called VBID X. You could learn a lot about that on the VBID Center website. You'll see here that VBID X, the basic premise is when you help us identify high value services. Next slide, Brantley, please. Sorry. This is the example of robbing Peter to pay Paul. You spend less on low value care, you spend more on high value care. But very importantly, for the people that you work with, to cover these high value services, you do not need to raise premiums, nor do you need to raise deductibles. Next slide. So we put out a template that you all could look at that's available either on the VBID Center website or now in the Federal Register. Here are some services that we believe that should be covered very generously. The next slide shows that this does not only extend to generic drugs, but includes a few branded drugs where they're not generic equivalents. And these are paid for, next slide, by the identification of services that the evidence deems do not help patients in many situations, which is a non-coverage approach. And there are other services that we just raised cost sharing on to make the actuarial calculations work. Next slide. So we were thrilled and astonished to see the VBID X idea published in the Federal Register in the HHS 2021 final payment rule, suggesting that there is interest in this high value care, low value care trade-off. Next slide. And we count on folks like you to be able to build the data sets to bring about the point that there is an infinite number of plausible combinations of services and cost sharing strategies that can lead to a cost neutral benefit design. So my second to last slide, Brantley, please, really wants to create momentum for all of you to drive forth enhanced access and affordability to essential services by putting in place programs like pre-deductible coverage for high value services, identify and measure the low value care that you could help us do, as we've shown already in 4 states and others are doing it now, and then put it all together with these cost neutral trade-offs, VBIDX designs that will allow us to spend our money wider. So ideas are easy, implementation very, very hard. Next slide is my handoff to my colleagues and my champions from the Commonwealth of Virginia. You may see this slide, but I use it all the time. And as I turn this over to Beth Ports, I want to thank you, Brantley, Sarah, and Norm, and the NATO folks. And most importantly, thank my colleagues from the Commonwealth of Virginia who've gone beyond talking the talk on low value care, what I do, and actually walking the walk and getting rid of it. And with that, I'm happy to turn the virtual microphone over to my colleagues, Beth and Kyle.
Thank you so much, Mark. Really appreciate that. While we're waiting for our slides to come up here, just a little bit of background. Here in Virginia, I run the Virginia Center for Health Innovation. We are a nonprofit that brings together all stakeholders across the state interested in accelerating the adoption of value-driven healthcare. We work very closely with VHI and Kyle Russell. They are our data source. And so at a point in this presentation, I will be passing the baton over to Kyle to share a little bit more detail about the data side. And slides I think are coming. It's just taking a second. So I'll start and just share with you that as we were working to try to figure out how can we measure if we are making a difference in accelerating the adoption of value-driven care, we quickly came to the conversation of we need to be able to measure what we're doing and see if we are successful. And so that led to the creation of a Virginia Health Value Dashboard. And I'm going to pause just and see if we're getting closer to slides. There we go. Okay, great. So next slide, please. So the Health Value Dashboard, as I mentioned, this was really about how do we show all of our stakeholders that we're making a difference. Next slide. We focused on 3 main aims: reducing low value care, increasing high value care, and really making sure in the Commonwealth that we have the infrastructure in place to measure and reward value. Under each of those aims, we identified a handful of indicators for those measures. So you'll see things like utilization of avoidable emergency room visits, low value services as captured by the MedInsight Health Waste Calculator, and preventable hospital stays. I'm going to focus most of these comments today on B, there under aim 1, the low value services. Next slide, please. So VHI helps us with data from the state's all-payer claims database to put together a dashboard. You'll see this dashboard, and it's not meant to be an eye test. If you really want to dig in, you can visit our website. But really, it's supposed to be a snapshot looking at how are we doing by region of the state on the different indicators and measures. Next slide. It's important to know that we have a future measures work group that is constantly assessing new measures for the dashboard. We want to make sure that we are always incorporating the best data and any changes in the measurement science to have the dashboard be a strong document. So you'll see coming in 21, we will have a new low value care measure looking at antibiotic stewardship. And then we will have 3 new measures that look at the increasing high value care side. Next slide. And there's detail on those. And we work really hard to use NQF measures, PQA measures, anything that's been vetted. It's not to invent these ourselves in Virginia, but to put that information out there. Next slide. So as we started to look at the dashboard, you saw that there was reducing low value claim. We then develop initiatives to drive improvement on those measures. And the biggest of these is Smarter Care Virginia. Next slide. So Smarter Care Virginia is focused on reducing low value care. There's some important things to know. We based it on Choosing Wisely. Choosing Wisely is an initiative that came out of the American Board of Internal Medicine to identify medical tests and procedures that providers identified that they know to be unnecessary. We use data from our state's all payer claims database, and as I mentioned, the MedInsight Health Waste Calculator. Next slide. When we started running data from our APCD through the health waste calculator and wrote it up with some help from Mark Fendrick, who's already presented here, as well as John Maffei from UCLA and the team at Milliman and our Virginia Secretary of Health and Human Resources, we got a lot of attention. And that really led us to thinking about how do we implement a program to address this. Next slide. So what you'll see here is data from January 2020 from the Health Waste Calculator. And when we ran that data, that had 48 low value measures in there. Our data includes Virginia commercial, Medicaid, and Medicare data. You'll see that we saw in just those 48 measures about 539 million in unnecessary care and 1.72 million unnecessary services. Next slide. When you break it down further, 36% of members were exposed to at least one of those low value services. 31% of services measured, those 48 were considered to be low value. And that resulted in over $8 per patient per month in unnecessary claims. Next slide. When we looked at those, we've learned that there are different ways that you can assess how big the problem is. Obviously, there's the cost factor, but there's also the risk of harm that could be conveyed to a patient from this service. And the low value index there on the far right side suggests how often a service is being performed that it is considered low value. And so in Virginia, we really wanted to focus on those that kind of hit many of these indicators, but ones where we felt like we could make a significant difference. Next slide. So we put together a proposal and were awarded a $2.2 million grant from Arnold Ventures to do a 3-year initiative that has a 2-part strategy to reduce 7 sources of provider-driven low-value care. We chose specifically measures from the waste calculator that we thought clinicians were the ones in charge of ordering, not things that patients come in and ask for. We figured we would focus on consumer driven in phase 2, since that adds a different element that has to be controlled for. Next slide. So Mark shared this. So we have a clinical learning community that's working to reduce those 7 measures. We created an employer task force that includes 17 employers across the Commonwealth that are working to learn about low value care and then work with their plans to drive change. And together we are working to create a statewide plan to improve health value. Next slide. To give you a sense of our clinical learning community, if you're not familiar with Virginia, we have 6 of our larger health systems, and that also includes 3 clinically integrated networks that are associated with those systems participating in this initiative. Next slide. Together, those 6 systems represent about 1,000 practice sites, 7,000 clinicians. It's all of our health planning regions. They are working on the active intervention for 18 months. We did have to re-strategize with the COVID situation. We have a data pause, if you will, in our study from March until September. We changed from step wedge until using other systems as a control, and all 6 now will be going together. but they're all eager to participate and are working to execute their plans. Next slide. So what do we do for them? The biggest thing that we found that providers needed to make a change was they need to see their own data. They need quarterly reports where they can see how they are performing on each of the 7 measures. We do also provide them with CME webinars. They have access to faculty's office hours. We have project leadership calls. Each of our health systems has created a clinical leadership team, and they all have a monthly call. And then there is an online platform, which has a host of resources for them. But it's really about those provider performance data reports. And so I'm going to pass the baton, I believe. Next slide. To Kyle Russell, and he's going to talk to you about those reports since VHI is the one that prepares them for us. Kyle.
Thanks, Beth. Good afternoon, everyone. So again, my name is Kyle Russell. I'm the Director of Strategy and Analytics for Virginia Health Information. We're the state health data organization for Virginia, and we administer several different programs, but the most relevant for here today is the Virginia All-Payer Claims Database. So as Beth mentioned, it takes a lot more than just data to make something like Smarter Care work. But the data and quarterly benchmark reports from the APCD are somewhat the meat and potatoes of what gets pushed out to all these systems as part of their participation. And it takes a lot from multiple different organizations to make something like that work on a quarterly basis. And so I just have a few slides just to give you a flavor of what gets pushed out, but in no means is it all the details of everything that has to go into something like that. If you do have questions, we're happy to answer it after the fact, but again, really just give you a high level overview. So the nice thing with the setup that we have in Virginia is that we've worked with VCHI and VBID and Milliman for a while. And so within the APCD, every time we refresh the data, even before Smarter Care, the Milliman Health Waste Calculator is run against all the results. And so we have all that output ready to go. And so for something like Smarter Care, all we really need to push out benchmark reports to everyone to get things kicked off are their MPI rosters. And so once we get that, we can then tailor down to each system to give a system their own results, but then also give them the flexibility to filter that down by practice, by practitioner, however many different ways they want to work with the data. Because of the infrastructure that we've been able to build over the past several years and all of the interest that Beth and VCHI have been able to generate in low value care, we were able to launch this pretty quickly for the grant for what's being asked. One last point I'll make on this slide is that I'm sure all the other states on the phone know, when you start talking about the data and you talk about something like an APCD, you always have to list all of the limitations and the caveats and talk about that it's not a perfect system and that certain data is missing and, talk about all the blemishes. And that's the same case here. When we talk about the benchmark reports, we're very transparent in what the APCD can and can't do. And typically what happens is, you present to the system and they say, well, that's not ideal. But then we always give the alternative that, well, you can use the APCD, or if you want, we'll give you all of the ingredients and building blocks to try to build something yourself on your own internal data. And they go back and they look at their internal data limitations and just the sheer amount of resources and everything else you have to put in to do it. And they all came back and said, hey, even with the blemishes, we would much rather use the APCD. That would be great for us, for you to design these and push these out. So that's really our role at VHI to support VCHI for Smarter Care. We leverage the APCD to push out reports, typically through Tableau, to all the different systems, and then we customize them however they want. And there's been several customizations that have been made from each of these different systems. So they come back and say, well, what if you did this? What if you added this variable? What if we added these different dashboards? And so through the Arnold Foundation, we have the resources to push that out to them. So all they have to do is say, hey, we like this, and we don't have to worry about it getting bogged down maybe in their own internal IT queue to make sure we get the results they need to make sure this is effective. So next slide. So here is just a snapshot just to show you there's a couple major themes in what we present out to each of the systems. The first is a high-level dashboard view. So something for a practice administrator or someone that is overseeing multiple different practices. And the main things we try to emphasize are distribution and benchmarks. So within a practice, who are your outliers, so to speak? What does the distribution look like? Who's doing a high volume of services also at a very high rate of them being low value? How do they compare to the rest of the practice? How is it distributed? And then put that in context of how is the rest of your practice doing? How's the specialty overall doing? How's the rest of the system doing? To provide some context to know who to target for interventions to try to reduce your given system's rate of low value care. So next slide. We couple that with reports that were requested upfront from systems on something that's more intended to be shared with an individual practitioner. So you might use the first example to identify the practitioners you want to have an intervention with, but when you actually go to speak with them and talk to them, we need to make sure they have the resources on something you might print or something that could just be shared that's individual physician focused, clearly shows their rate compared to benchmarks, and also has clear recommendations on when a service is appropriate and when it is not, because all of the low value care measures from the waste calculator are never 100 and 0%. There's always clinical nuance of, there's a range. When we look at the results, sometimes 8% of services might be low value for a certain measure, all the way up to 90 for another. And so the recommendations are really key to make sure you interpret the results, and so that they know this is not a blunt instrument to gauge their performance. This is definitely something that takes a significant amount of time to build in all that nuance when we look at the data. So next slide. And then lastly, what we have found is that we push out to the systems the high-level view, the individual view, and we almost always get questions back or requests for dashboards that look at things a little bit more granular. So they might say, well, we want to focus on the baseline labs before low-risk surgery. So we always get requests back to say, well, that's great, but we actually want to know what are the baseline labs and what are the surgical CPT codes that are being billed for this practitioner, and how do they relate and how are they distributed? And so a lot of times we're the workshop of taking those and say, here's that next level, as they look through the results to interpret how to make it as actionable as possible, whether that's physician intervention or billing practices. Next slide. So from our perspective, just to reflect on where we are at Smarter Care, and for all the state organizations and administrators similar to our position, similar to our position, and what you might be doing in your state if you wanted to replicate something like this. I can't speak enough how beneficial this program and just reporting on low value care and the partnership with BCHI has been to the overall reputation and interest in the All Payer Claims database. So we started as a voluntary program, and we eventually became a mandatory program last year and restructured with that and received state funding to help support this program. And there's no way there would have been the interest and support for that mandate and that funding without the work that we have done on Smarter Care and low value care reporting. Because really what it does is it takes, for us, the APCAD from being predominantly used for research and transitioning that into something that's actively being used for clinical decision making, which is really one of the goals from the beginning on what an APCD should be used for. And so while it's not perfect, and we are always very transparent on that, the nice thing about something like this is that the APCDs are the best data source that is available. Their data from an individual plan won't cover it. If a system wants to use their own internal data, it might have less lag, but it's only going to just be their claims. There's no benchmarks. The APCD, faults and all, is for something like a Smarter Care, low value care is great to have all the coding and everything else pushed out and ready to go. But again, just to emphasize that this reporting has really been the flagship of what we have put out from the Virginia APCD. Nothing has generated more interest. I can't imagine us getting a grant of the size that what VCHI has been able to pull for something else, or not having that great partnership that we've had with VCHI along the way. And so, we're happy to answer as a group any questions you have, but I just can't emphasize enough, if you have the opportunity to do a project like this over time, I really feel like it is incredibly beneficial, and I couldn't recommend it more from the state perspective. So with that, Beth, I will hand it back to you if you have any. I can't remember if you have a few more slides or if you just want to have some closing comments.
Great. I think we can just open the floor for comments, because I think the last slides that were there, Mark had already covered. Just letting you all know that we participated in the 4-state report, which he shared. So at this point, I think we can turn it back to our facilitator.
Okay, thank you. That was amazing, Kyle. And Beth, both of you guys. It's really great to see how the data is being used in that clinical way that I think you guys are really implementing real change. So for those who may or may not be aware, there's a Q&A section that people can type in questions. So we do have a few questions. So if I just want to direct people who may not be familiar, it's in the top right. Sometimes it'll be pulled up as sort of a sidebar, or it could be just sort of a little blue arrow. And if you click that, it'll pop out as a sidebar. And then the Q&A section is on that far right-hand side. And we really invite people to participate. There was an earlier question about, a lot of these software that identify low-value care can have very large licensing fees. And so someone asked, are you aware of any other options to specify these services? And Mark did respond to this already. He sent out his email, and he said, those special pricing that are available for APCDs and other organizations. So look for those discounts. I actually had a friend who said, never buy anything full price. There's always got to be some discount you can get. But I'm also curious, Kyle or Beth, do you guys have any other thoughts on that, about any other options that people could look at if they don't have the funding?
I would say, if you are interested as a region or a state in moving forward with this, I would encourage you to reach out to me, and I'll put my email in there as well, because we are looking to see if maybe there's a 2.0 version of all of this, that we can share the lessons that we've learned in Virginia and bring a next group together. So I would encourage folks that if this is something that's really on your to-do list, to reach out to us.
Thank you. One of the organizations I'm in, they say don't do it alone, and I completely agree. This healthcare cost is a national issue, and I think that as all the states work together, we can find a good way forward. So the other question that I have, and then we'll move on to the next topic, because we want to make sure we have time for this and questions at the end, is how much lag is the APCD?
Sure. So for this reporting, we basically found that if Medicare fee-for-service isn't included in the vast volume that represents, people would rather wait and have it be more lag to be able to get that data. So we're on a quarterly cycle with CMS and get it as soon as we can, but it's like, for instance, we just released data through the third quarter of 19. So it's about a year. If you cut out Medicare, it's, we have data into 2020 for everybody else, but we're basically beholden to CMS releasing fee-for-service data plus reasonable processing time to distribute out. But we actually adjusted our processing cycle so that we basically only run the bare minimum to be able to generate the Smarter Care reports. So it's like halfway through the cycle, we push these out to make sure we get them out as quickly as possible. So that's maybe another advantage with something like this too, particularly that's grant funded with deliverables. It pushes us to be faster. So upfront, we had to be creative, and I know Beth and I had conversations around like, can we do court? You know, like we can live up. Because I can tell you 4 years ago would have been difficult. So I think that's been just good for our operations, and that we had to reflect and do some things. And then since then, we have been able to hit that with, again, the lag that frankly is just unavoidable if you want to include Medicare claims.
Thank you, Kyle. Yeah, I agree. I think, having a project and having a goal really does help timelines and streamline things a little bit more. Okay, so we're going to transition into our next set of speakers. We have David Keller, and he is a professor and vice chair of clinical strategy and transformation in the Department of Pediatrics at the University of Colorado School of Medicine and Children's Hospital of Colorado. He's also currently co-chair of the Colorado Primary Care Payment Reform Collaborative. And then Tara Smith is the Primary Care and Affordability Director at the Colorado's Division of Insurance. Tara has been actively involved in efforts to reform state healthcare system through her career, including Colorado's State Innovation Model Initiative and implementation of the Affordable Care Act's health insurance marketplace reform. So we were very interested to hear from them and to see how primary care can play a role in reducing unnecessary costs. So I'll go ahead and hand the time over to you two now.
Yeah, hi, this is David Keller. For some reason, my camera will not turn itself back on, so I'm hoping you can hear me because I can see the little thing flashing on my screen. You also should be looking at a slide that has our title slide. So if we can go to the next slide, I'll talk a little bit about the primary care spend and why we care about it. I was pleased to hear at the plenary, there was Dr. Rittenhouse spent some time talking about the challenge of primary care over the last 10 years, that primary care practices have been pushed to transform in a variety of ways, and then COVID knocked the legs out from under them, that the cash flow in the spring has been severely impacted by the fact that we are still largely in a fee-for-service system, and that with COVID, our services, which are again largely visits in our offices, just dropped precipitously. I'm a primary care pediatrician, and I can testify that happened. We switched to telemedicine for some things, but as a pediatrician, for example, well care couldn't be done by telemedicine by and large, because we have to accompany it with vaccines and other things that go along with that. So it's been a challenging time for primary care, and this project came into being based on the last 10 years of experience, where a number of us have been trying to figure out how do we get the system to invest in primary care going forward. And one way is to measure the amount of primary care spending that's going on in the community, and then through a variety of means, encourage payers to invest more. This is a conceptual model of the primary care spend, and it shows that if you look just at the percentage spent on all essential primary care healthcare services, you can invest in that area and increase access and equity. And then if you start looking, as our colleagues just told you, to look at what's high and low value within those practices and push people to provide first contact, continuous, comprehensive, and coordinated care, we can also increase effectiveness and efficacy. This was first tried in the state of Rhode Island with some success and is now rolling out to other parts of the country. Next slide, please. We have noticed over time, and all of us know, that there's something different about total healthcare spending in this country, and this is the Office of Economic Opportunity grant showing the OECD countries and how the total spending is different in the United States. I don't need to belabor the point. We spend a lot of money. The other thing that's different about us is if you look at us compared to the other European and other advanced countries in this, that we spend a much lower percentage of our total healthcare spend on primary care. In general, we spend between 6 and 8% across the country, and the other countries that spend less in total spend a lot more of that on primary care, up to Estonia, which spends a remarkable 25% of its total healthcare spend on primary care. Next slide, please. So we think this is a recipe for value. And the key to making it work at a state level is to convene all the stakeholders, define and measure the primary care spend, define and measure affordability standards from the public standpoint. What is it that we want to invest in primary care that is going to help reduce the cost, bring the affordability of healthcare back out of the stratosphere? How do we rig it so that these investments are in high quality primary care? How do we assess the impact on affordability, quality, and outcomes? And how do we continuously improve these initiatives? If we do all of these things and sit and stir for about 10 years, like they did in Rhode Island, you can get very good results. Next slide, please. So this is from a study that was released last year from the Primary Care Collaborative that showed the variation in primary care spending across the country. And that spent different amounts. In particular, Minnesota seemed to invest a lot in primary care, and some other states spent less. Next slide, please. They then looked at avoidable hospitalizations across those same ranges. And what we found is there was a definite association between the spending in primary care and the percentage of avoidable hospitalizations across the country. This is the kind of evidence that's out there to show that this approach is going to be effective in the long run. And well, we in Colorado decided to implement it. So 2 years ago, we passed a law that required the state to convene the Primary Care Payment Reform Collaborative. And that collaborative is been working for the last year to do the things that I talked about us needing to do to be able to use the primary care spend to help drive down the cost of healthcare through increasing investment in primary care. And at this point, I'm going to turn this over to my colleague, Tara, who will take it from here.
Thanks so much, David. I appreciate the handoff. So I'm here to pivot and talk a little bit more about how Colorado really is embracing investing in primary care as this recipe, right, to help us get to value. So as David mentioned, Colorado is one of about 9 states now that has either taken a legislative or a regulatory approach that to either starting to measure or benchmark investment in primary care with an eye toward increasing that investment over time. What this legislation did for us in Colorado were there were a couple of new things, a couple of new ingredients it added to our kitchen, just to continue a metaphor. First and foremost, it created the Colorado Primary Care Payment Reform Collaborative. And this is a very, very kind of cross-disciplinary stakeholder group that meets. You can see kind of the different components who are around the kitchen table here. We include healthcare providers as part of this. As Dr. Keller mentioned, he's a pediatrician, also family medicine and other types of providers. We have healthcare consumer representatives as part of this. We have health insurance carriers, which includes public, private, also employers who purchase and offer self-funded plans in the state. Some actuarial experts to help us with the tricky math, and some government folks. So the list of responsibilities that this collaborative has been tasked with is fairly large. I'm not going to read all of that. I think the 3 things that we're going to focus on here moving forward in this presentation are really that first role there. The role of this group is to advise specifically the Division of Insurance in the development of affordability standards. And those affordability standards include a target level of carrier investments in primary care. We're using APCD data to help us measure this from the start, both in setting the targets themselves, being able to track those and evaluate. So going to be focusing on that part of our story. And a key part of that has also been developing this recommendation of primary care. So if you want to add to the next slide. In the interest of time, I'm going to talk about this at a very high level. I'm happy to answer questions about this. I just wanted to put this work in the context of the affordability conversation that's occurring in Colorado right now. We think and believe that primary care is foundational to getting to a high value, high quality, well-functioning healthcare system that reduces costs. We know there is not a singular approach that's going to get us there. So the slide is just to highlight some of the other work going on in the state. There's a series of initiatives that are really looking at affordability with that consumer lens, focused on premium reduction. There are complementing the cost reduction conversation, other strategies around utilization and quality of care. And so that's kind of the side of the affordability tree that that our work and the Primary Care Collaborative lives on. Next slide, please. So in terms of where we are at in our cooking process, right? So this legislation was passed last year. This collaborative started meeting in July, and by December of last year had produced a report that had an initial set of recommendations. Again, these recommendations were to inform the division, which is why you have an insurance regulator as part of your panel today, in developing the affordability standards in the form of a regulation, right? And then we had COVID hit, which has kind of put some of this work on a temporary pause, but we are starting to move forward. The other thing that I want to really highlight on this timeline, the top elements of the timeline, all those bars you see in blue are the contributions from our all-payer claims database. Those have been specific touch points where we have gotten direct reports from our APCD that are helping us get our idea around what is a baseline expenditure on primary care versus total medical expenditures. We have these regular touch points set up throughout the process of our timeline. So want to focus in on that particular piece in the remaining slides. So next slide, please. So as we think about measuring investment in primary care, and our colleagues from Virginia couldn't have said it better, right? We want to be able to measure the impact of what we're having and what we're trying to achieve. So as we are thinking about, and particularly where we're at in our process, measuring primary care expenditures has two kind of dimensions to it, right? Equal sides of the same coin. We need to be able to measure spending both in primary care as a percentage of total medical expenditures to be able to implement anything like a spending target, right? So we need to be able, through the use of data, to operationalize a definition of primary care in and of itself. What are we counting as primary care spending? And then we will need that both. We've used that to set the targets. Now we will need it to actually get that baseline measurement, track them over time, and be able to investigate and be able to determine whether or not our commercial insurance companies that are under the DOS regulatory authority are meeting these. So just quickly, so you get an idea of what we're talking about, the primary care investment target that Colorado established, it's a 1 percentage point annual increase in primary care expenditures as a percentage of total medical expenditures occurring for 2 years. As we've collected baseline data, we want to see what is happening over time before we set a long-term target. We have an additional target around alternative payment models. Apologies for the typo on the slide there. It's APMs, not AMPs, that we're looking at setting a target of 50% of total medical expenditures. As we're thinking about this is not just increasing the dollars that are flowing into primary care. We want those dollars to be invested in things like value-based care that can improve both quality and outcomes and also get us to the cost reductions that are a key part of this. As we're looking forward, as we actually start baking our affordability pie or cake, we want to be tracking short, medium, and long-term measures associated with us. And also, are these investments having the desired impact in terms of how they are supporting primary care providers in adopting the types of care delivery models, again, that we know are going to help us control costs. Next slide, please. So the pieces, the tools that we have identified to date are really getting to this definition of primary care, which we are basing on provider and service types. Again, as David mentioned in that previous report where you had calculations of this, the amount of primary care spend that you're getting depends on whether you're using a narrow definition that's limited to specific primary providers, or if you're expanding that and using a broader definition, I would just highlight that Colorado is using a broader definition. Things like OBGYNs and behavioral health providers, when they're practicing primary care in a behavioral health or integrated setting, are included in our definition, which creates some operational challenges that will hit right as I'm wrapping up. I want us cognizant of the time in Q&A. To actually make this calculation, it's a deceptively simple formula, right? We're looking at primary care investments, both claim-based and non-claims-based, over total medical expenditures. So next slide. So we have some of our great colleagues and expert Maria on the line from Civic to help us field some of the questions. Just for other states, in terms of using APC data for these kinds of policy functions, there are different kind of snags and or issues in the process that lead to decision points. So with primary care, particularly getting to that definition, defining provider types and services that you're including in primary care can be a little bit challenging. And some of the reasons taxonomies aren't always reliable. You get providers that are technically classified as primary care aren't solely primary care, that may be working in other settings. So how are you focusing in on claims where you're getting those providers who are working in a primary care setting, primary care capacity? And again, an issue with how are you identifying behavioral providers that are working actually in an integrated care setting, which is what we're interested in when we're thinking about primary care spend. So our initial solutions was to use a combination of taxonomy and CPT codes. We're also to be able to get the behavioral health that are in an integrated setting and some of the other providers. We're including claims that are associated to a primary care billing ID as a somewhat, we'd love other ideas on how we can better capture that data, but that's where we've landed now. Next slide. On the alternative payment model side for the non-claims-based payment, there are also some operational issues. We wanted to be able to segment it by line of business. That took an additional element that was needed for our APCD to collect. In terms of APM spanning categories and how carriers are reporting across categories, that can be a very challenging exercise as well. So we have adopted a national framework, the LAN framework. Again, happy to answer that in Q&A. And I'll turn it back over to you, David, for a quick touch point on COVID, and then we can open it up for questions.
Yeah, so when we submitted this abstract back in February, COVID was just on the horizon. And obviously, if you look at our second to last slide, the COVID-19 has changed everything. It has, as I mentioned earlier, had a tremendous impact on primary care practices as patient priorities changed, in-person visits stopped, and telehealth rules changed and use ramped up. Employment has been disrupting, which disrupts our insurance coverage. And we're currently, like everyone, experiencing a rise in Medicaid and the fall in commercial insurance rates around the state. So how has it impacted our mission? Initiative is actually the big task of our collaborative right now. What is the impact on the measurement of the primary care spend when people don't go to primary care? What is the impact on the measurements of clinical quality? And a number of the measures that we've used, and I think that you heard referenced in the previous recommendations, have been it's not clear to me that the benchmarks are reliable anymore. And I think we're going to need to stare at that a lot. What has that meant for APM implementation around the state? And then coming back to yet again, what is the impact of telehealth on all of this? I think these are all things we don't know. So it's kind of like we're navigating this whole thing in the face of the storm of COVID, but we still believe that even in the face of COVID, having a robust primary care infrastructure is the best way to deal with that and with everything else. And we can put all of this together into a model that is going to make healthcare more affordable to families over time by encouraging investment in a robust primary care system as we keep it alive through COVID and expand it into the future. And that's where we're going to stop. And I think we have 1 minute left, maybe, for questions.
Yeah, thank you so much. This was really good information. And I think, yeah, we don't have any questions typed in right now. And we are at the hour. But I just want to thank everyone again for the participation. And one of the things I want to say, even though our question and answer was cut a little bit short, I would encourage all of the audience to reach out to these presenters. Accelevents makes it easy to connect with people, and that's one of the strengths of having this NARA conference. Not only will we can hear these great discussions, but we can continue the conversation offline. So I would encourage you all to participate and do that. So thank you. Charles, do you have any other last comments you'd like to share?
Yes, thank you, Brantley. So one thought is that the next session, well, let me just make a quick plug on Brantley's point. There are some networking sessions that are coming up. Feel free to join those. Those are an excellent opportunity to get to know folks as well. And then the next session that's coming up is on the NASHP site. So like yesterday when we switched to go to Governor Baker's presentation, you'll have to click onto a link. Hopefully this time we'll have less issues with Accelevents. But so far so good. So that's kind of the next session. I just wanted to call that out for everyone so that you know where it is. Otherwise, thank you and have a good rest of your day.